Вітаємо усіх, хто сьогодні цей вечір присвячує професійному розвитку у сфері ментального здоров'я.
Greetings, dear participants, and whoever is dedicating this time to professional development and continuous professional. This webinar is dedicated and created by the Coordination Center within the All Ukrainian Program for Mental Health. How are you? Was the initiative of the First Lady of Olena Zelenska. For the 8th webinar, we are selecting the most needed topics for Ukrainian specialists, and we are welcoming the leading speakers to share with their knowledge, with their practices that can help with our experience and what we're facing. This is also because of your request, dear participants. And over 1,500 people registered for today's meeting, and we are expecting to your active participation both in the chat and Zoom, on Facebook, or Coordination Center, and also on the YouTube channel. How are you? In the nearest an hour and a half, this platform will be working for all of us here. So today's talk will be very useful for psychologists, psychotherapists, psychiatrists, and social workers, and every aspect that is working with children and adolescents that went through traumatic events. We will be speaking of the influence of pediatric trauma and the reasons of the early stress, methods for prevention and practices. And also we will face the interventions and neuroscience as well. And I'm so happy to present to you our dearest speaker, Victor Karian, the professor of Department of Psychiatry and Behavioral Sciences, named Dr. Jordan Turner, the Deputy Director of the Department of the Behavioral Sciences and Stanford University, the head of the program for early life stress and resilience program. Dr. Karen, greetings in Ukraine. Thank you so much for joining us, and thank you for being here and ready to share your experience with Ukrainian experts that in the same way are happy to learn more from you. And I'll pass happily the floor to you for the next hour. And after the next hour, we'll have the questions and answer session. To you, dear participants, just like to remind you that you can always leave your questions in the chat, and we will be voicing them for Karian in the end of the meeting. And also a small reminder for participants that are with us from Ukraine. We know that right now in a list of oblasts of Ukraine or regions of Ukraine, there's an error word, but yet again, please don't negate your safety. We are trying to make it possible so that you could view our webinars in recording. Therefore, please stay safe. And Dr. Kariat, passing the floor to you. Thank you so much for being here. Thank you.
Yes, thank you so much for this invitation. It is a pleasure for me to join you today. As it was said in the introduction, there are a few subjects that are of more relevance in our time than how to take care of our youth when they experience trauma. Contrary to what most people think, children are not resilient by virtue of being children. We know through the scientific literature that the opposite is true. Children are more vulnerable. That's why we take care of them, and that's why we need to develop interventions that help them with the problems that come their way. Today, we're going to talk about two of such interventions that have been informed by work that my laboratory has done in the past 30 years in the field of stress and neuroscience. So I am trying to, there we go. The outline for today would be, we are going to talk about the consequences of trauma, how they demonstrate behaviorally. We used to define them, and we still do behaviorally. But in the past 30 years, we really have had an attempt to really define more this in terms of biological markers. I'll talk about some of those in terms of a stress hormone, cortisol, and also in terms of brain structure and brain function. And more recently, some work that we are doing in my island of Puerto Rico on the epigenetics of resilience. We'll talk about the strengthening of the child and two specific strategies. two specific interventions. One is a prevention and one is a treatment. For prevention, we utilize a curriculum of yoga, body movement, and mindfulness. For treatment, we utilize a treatment that we develop in our program called Q-Center treatment. And we will present the research in both of these, and then also talk about our current work in schools. Behavioral aftermath of trauma. Most of us know that the interaction between gene and environment is pivotal, is critical. We know that it's not nature that is responsible, and it's not nurture that is responsible for our behavioral outcome, but really an interaction of both of this that's going to impact our stress vulnerability, and that would lead to things like resilience or conditions like PTSD, anxiety or depression, or anything, really, anything physical or mental that the body is at risk for developing. Notice that we're not talking about getting rid of stress. We're talking about getting rid of traumatic stress. Stress operates in an inverted U-shaped curve, where if we don't have any stress at all, that also means that we have very low health and very low happiness. Our immune system, right, develops through vaccines and through the exposure to insults. And in the same way, our mental health adapts in terms of developing coping skills and developing strategies up to a certain level, up to an optimal point in terms of stress. After that optimal point, in that second part of the curve, we can see all of that decline, the performance, the happiness, the health, and that is where traumatic stress resides. So what we want to do is shift the curve of each individual to that optimal point, not necessarily to get rid of all stress in their life. During the time that we have today, I'm going to be referring to a child that experienced interpersonal trauma, not man-made trauma or natural disasters, which are other types of trauma. And sometimes individuals can experience all of the above. But Sammy is a sixth grader, an 11-year-old boy who was brought to our clinic because of increased aggression toward his siblings. The mom reported that this was very uncharacteristic of Sammy's previous demeanor. She also reported decreased academic performance. The mom felt guilty, felt confused, and she reported to the authorities that Sammy's father had regularly abused her and the children physically and emotionally for a number of years. Sammy had been hit numerous times with metal bars, wooden rods, bamboo sticks. Sammy's mother felt the boy's behavior was directed at her for breaking the family up. Moms and kids were now living in a new apartment after the father had been arrested and deported. Sammy had nightmares and difficulty sleeping, and he scored 32 in the PTSD reaction index, a measure of PTSD, which indicates moderate post-traumatic stress disorder. What we see in this case is that much of the behavior changes. So it's not like Sammy was like this all the time, but after the traumatic event, his personality changed, his academic performance changed. We also see that there's a very concrete trauma of physical abuse and emotional abuse, but we also see the sequela of this, of his father being deported, of him having to go to a new school, and all of that. So we will be referring to Sammy's case as we move forward. In terms of having a condition such as post-traumatic stress disorder, the first thing that we see is that there's a threat of death. There's a threat to the physical integrity of the individual. And this can be directly, this can be witnessed, it can be to someone that is close to us, or it can be repeated in indirect exposure. Something that is not here in the criteria is that children that are very young, younger than 7, younger than 6, sometimes do not understand the concept of death. So for them, death is not the worst things that can happen to them. The worst thing that can happen to them is separation from those that are providing security and safety to them. So separation from their caretakers. So in that sense, for very young children, a separation would qualify, in my opinion, as a criterion A for very young children. Then we see a whole host of symptoms, some of which we can all develop when exposed to trauma, and sometimes they go away. But in some individuals, it persists. And sometimes it's not due to the last traumatic insult, but it's due to the accumulation of the traumatic insults, something that we in the scientific world call allostatic load. And in my team, we call it the backpack. You can see a little girl here carrying a backpack, and we are built to carry backpacks. But sometimes if we're very young and the backpack is very heavy, we can fall backwards. Some of those symptoms are symptoms of intrusion, nightmares, dissociative reactions, distress upon reminders, marked physiological reactivity. A note here on dissociation. For many young children, dissociation is a normal defense mechanism, but very much like a white blood cell, if we have too much of it, we can develop a leukemia. We can develop a dissociative disorder because we are dissociated all the time. And that can affect the amount of information that we encode and hence the amount of information that we retrieve as well. In here, we can see one of the worst outcomes of intrusion is that trauma takes over one of the most important developmental aspects of a child's life, which is play. In here, we see in this drawing a child exposed to war. We can see that the face of the children are not enjoying what's going on. There's a facial horror at the bombing of this situation. Trauma is is very important during development. Through play, we develop socially, motor-wise, we develop in terms of emotion and expressing emotion. When trauma takes over play, then play doesn't serve that function anymore. The function that it serves is to communicate what the child may not have words to express. And that is a symptom of intrusion. Here is a girl narrating to us after an earthquake in Haiti, how she and her sister were the only ones found on the rubbles. Another example of play taking over, traumatic play taking over. And another group of symptoms are symptoms of avoidance, symptoms of not wanting to talk about it, not wanting to address it, which is very different than really finding the best time to discuss it. That is different, right? If we have to triage and we have to say, well, today we are taking care of A, B, and C, and we'll deal with D, E, and F during the weekend, that doesn't mean we're avoiding them, especially if we do them on that weekend. But to avoid all thoughts, all feelings, all reminders is just going to make PTSD stronger. In my lab, we have a saying, which is that PTSD feeds on avoidance. So we want to do the opposite of avoidance, which is approach. And therapy is approach. And then negative alterations in terms of how we think and in terms of our mood. In the past, many kids used to get another diagnosis of major depression. Now we realize that sometimes this depressed mood really is associated with the post-traumatic experience, feeling alienated from others, having a more constricted affect, and having negative trauma emotions. Also, alterations in our arousability and our reactivity. We say that the kids become hypervigilant, that they are aware of all their surroundings all the time, and that this can be exhausting, and that this can bring excessive anxiety. Of course, developing hypervigilance can be very helpful for someone who's experiencing trauma, especially on a chronic context. But one must have the cognitive flexibility to know when to turn it on and when to turn it off. If it's on all the time, it really can be, in a way, self-destructive. But here we also see problems of concentration, difficulties with sleep. All of this enters this. We see that this lasts longer than a month, that it affects function, which is really the cardinal mark of a disorder, that it affects academic life, social life, it gives distress, and it's not caused by other situations. So when these symptoms are happening because of the experience of trauma, what is happening to that 100 billions of neurons, trillions of synapses that are pruning and are going through the process of myelination and connecting with each other as it's happening during early development? There we get to the biological markers of this behavioral description we've been talking about. And we're going to be talking about cortisol. We're going to be talking about limbic areas of the brain, such as the ones that process memory and attention and concentration and emotional life, the hippocampus, the prefrontal cortex, and the amygdala. And see how we can learn from them, not only to learn what PTSD is, but also to learn that what implications they have in treatment and developing treatments. Okay. The first thing is that we all have this system called the hypothalamic pituitary adrenal axis. And the result of this hormonal axis is the release of cortisol, a hormone that we secrete during the day to deal with the stressors of the day. The first stressor is to wake up. So cortisol is very high at that time of the day, and throughout the day, it decreases. And when we look at this hormone for the first time in 2002, we saw that the normal circadian rhythmicity of cortisol declining throughout the day was present in kids that have history of post-traumatic symptoms in the same way as it was doing in healthy kids. However, before bedtime, the levels of cortisol in the group that had PTSD were significantly higher. As we have kept looking at cortisol and looking at this level, this finding has become stronger. The levels of pre-bedtime cortisol are very elevated in children that experience trauma and have post-traumatic symptoms, especially during the first year. The system kind of auto-regulates, and actually chronically what we can have is the inverse. We can have lower levels of cortisol. But while they're high, we were concerned that cortisol and the analog in animals, corticosterone, has been shown to be neurotoxic to developing cells. This was in animal research done in mice and things like that. So we became concerned about what happens to kids when they have high levels of cortisol, and we started doing MRI work to look at the development of sensitive areas. And by sensitive, I mean areas that have these receptors for cortisol. So cortisol tends to go there more. We see that in terms of the amygdala, for example, and the hippocampus, both of which are in the limbic system, and then also in the prefrontal cortex, an area of attention, an area that we use for attention. But what we see in this picture also is the senses. We see the eyesight, we see the smell, we see the taste, we see the touch, the skin, and those senses are important because the senses are really the window to the central nervous system. And when we talk about our treatment and when we talk about cue-centered therapy, you will see how important those senses are in terms of the cues, in terms of the. So the first study that we did was to look at the hippocampus. And the hippocampus, in terms of morphology, in terms of, just taking a Polaroid of it, which is what a structural MRI picture is like, look normal size, look fine. But when we actually look at functional imaging, which is how is that hippocampus working during a task of memory, what we see here in yellow is the increased activity of this area in healthy kids compared to the kids that have post-traumatic symptoms. So it's having an impact in function. Also, we have shown in longitudinal studies that there is a correlation between the cortisol and the hippocampus size. Here we see the increased activity measured in voxels. This is a unit of measure for imaging processing. We can see the increased activity in the healthy kids in comparison to the kids that have post-traumatic stress symptoms. Then we focus our attention to that area in front of the corpus callosum, that's the prefrontal cortex, and that is responsible for attention, for concentration, but it's also the brake for the amygdala. And I'll get into that in a second. But what we find in the prefrontal cortex is that there are areas in the prefrontal cortex, like the ventral prefrontal cortex, that are smaller in volume in those kids that have the higher amount of cortisol. So once again, a correlation between cortisol and development of specific areas. When we do a task in functional imaging of attention called the go-no-go, which is very simple, it's about pressing a letter every time you see a letter, pressing a button every time you see a letter, except if you see the letter X, then do not press. That's the only instruction. We see that both control and kids with PTSD do and perform on this task the same way. But when we look at what's going on neurofunctionally, we see that it's different areas that become activated. The control group, and here on the first row, what we see is pictures of healthy children superimposed on pictures of kids that have PTSS, and then looking at differences of activity, we see that the middle frontal cortex is activating more. When we do the opposite and put the PTSD on top of the control, we see activity in the, not the middle, but the medial, which is what we see in the middle row here, in the medial part of the cortex, an area that is not supposed to be involved in this task of go-no-go. And this probably has to do with the comorbidity of anxiety and the hypervigilance that the children are experiencing, because that would activate the medial prefrontal cortex. And then you can do certain different combinations. In the last column, the last row, what we see is those kids that get engaged in self-injurious behaviors, those images superimposed over those that do not get involved in self-injurious behaviors. We see the insula becoming activated. The insula is a very insulated part of the temporal cortex, very inside of it. And we see that the insula activity is very much related to the severity of PTSD. The more severe, the more activity, the higher the score of the PTSD, that's what the CAP score is, the increased insula activity. So another area to pay close attention. And then the amygdala, what we see in the amygdala is a little bit more confusing. It is in the younger group, we see smaller amygdala than controls. In the older group, we see a larger amygdala than controls. There's an interaction between age and stress in terms of what happens in the amygdala. The amygdala is the emotional core of the brain. So that hypervigilance we've been talking about, that heightened arousability arises from activity in the amygdala. And then we have the prefrontal cortex, which was developed much later, evolutionarily, controlling that amygdala as a brake. We know now that the paths are more bidirectional, and sometimes the amygdala can control the prefrontal cortex as well. But let's keep in mind right now that the amygdala is the gas and the prefrontal cortex is that brake. Because when we do functional imaging in this group, by presenting angry faces and eliciting emotion, what we see is that amygdala activates very quickly in the group that has post-traumatic stress symptoms. And that's what we see here during the early phase in red. So some of you may be asking, why isn't the prefrontal cortex braking and controlling that increased activity? And what we see when presenting another type of faces, fearful faces, is that there's diminished prefrontal cortex activation in the PTSD group as well. So we have a heightened amygdala and we have a prefrontal cortex that is not doing its job as well. And cortisol can be part of the culprit of why this happens. So we've had a number, we know that some individuals are more at risk for PTSD, how close you are, the dose, if you have a family member that has developed it, a previous trauma, but now we see that high levels of cortisol, early amygdala reactivity, and diminished prefrontal activity are also markers of PTSD. So if we can develop a treatment that actually helps control that amygdala reactivity and increase that prefrontal activity, that would be a helpful development. And that's when we talk about strengthening the child. And that's when we talk about treatments, which is the part that we're going to talk about now. So we know that areas like the cortical area that I've been talking about and the limbic area are very complex areas of our brain. But the beauty of this is that the more complex the area of the brain is, the more neuroplasticity it has. And neuroplasticity means that it is open to the impact of good psychosocial interventions, that it can still change, that it can still adapt, that amygdala, for example, may become less active, that prefrontal cortex function may improve. Now, how do we do that? We develop a treatment that then we tested the same way with the same imaging methodology. But this is a very basic treatment. It is a hybrid component of different interventions that we know that work. But the main thing here is the empowerment of the child to develop self-efficacy. Because the reality is that if we think about a toolbox and we think about tools that a child may have, the word may gets in the way, right? They may have them, they may not have them. But something they will always have wherever they go is themselves, is their body. So whatever information they have, whatever they learn to do, that's a tool that's going to be there for life. They may not have it. They will have it. They will have it because it's within them. So self-efficacy and empowerment become very important. Many of the treatments require correctly so, that parents or caretakers are involved in treatment. What we were noticing is that there were many situations when this was not possible for whatever reason. The child was ready to do the work, but the parents were not, or the parents couldn't for whatever reason. So we wanted to develop something where the child was his or her own agent of change. So the secret here in Q-center therapy is not so much what is it, but it is how it is delivered. I'm going to talk a little bit about what it is so that you know, but then I'll talk about how it is delivered. So it is a short-term psychosocial treatment for children and adolescents who have experienced trauma. It's a hybrid of effective interventions. It has education, it has exposure. I'll show you those in a minute, but it's flexible. It adapts to the child's personality, to their developmental background, their age, and their current functioning, and is flexible in terms of the therapist as well. It adapts to the style of the therapist. It doesn't ask the therapist to change their style. It asks them to incorporate within their style some specific objectives that need to be met session by session. The simple triangle that we find in cognitive behavioral therapy, we turn into a square by adding another point of contact, which is the physiological change. Many children express their symptoms through headaches, stomach aches, and they're very somatic in a way. So we continue to work with cognition, behavior, and emotion, but we bring physiology into the picture as well. The components are, we start with education. So we don't jump right away to talk about what happens. This is not a trauma-focused treatment. It's a treatment that is Q-centered. What that means is that we want to know what are the things, the reminders that are causing you dysfunction by bringing the symptoms in, right? If there is something that is really threatening, that is not a cue. That is actually a threatening situation. That is not a trigger. That is actually a threatening situation. And your responses of running or getting under the bed or not wanting to talk might be appropriate responses for the trauma. So let's not confuse what's a threat with what's a cue. A cue is usually neutral. It's not positive, it's not negative, it's the color. And here are the senses that I was talking about. Is the color, is the time of the day, is anything that was associated through classical conditioning, like the Pavlovian type of law, into a response that was adaptive at one point, but now might be maladaptive, right? Running out of your classroom when you don't have to might be a response that was helpful at one point, but if now you do it all the time, it's maladaptive. So education for the child to understand that most of us will react in very similar situations the same way, and that they're not crazy, they're not bad, they're not a problem, which sometimes, unfortunately, is what kids hear at a very sensitive age of their development. So they incorporate those messages into their identity. So the education is essential. Then, even before we get into the chronic traumatic history, which is a big title for Show Me What's in Your Backpack, right? To the allostatic load. We get into things that may help them tell that story. So we get into things like mindfulness, like relaxation, like cognitive tools, and we never tell them you need to use this. They decide based on their experience, based on their personality, based on what they've learned, if they want to put it inside their toolbox or not. And then we get into this chronic traumatic stress history where we discuss positive events, neutral events, and negative events. And then, so that's first, we gather all the information like a journalist, and then we process the information like a therapist. Later on, we gave a mid-therapy update where we actually invite caretakers for the kid to give an update on what has happened, and we start working with cues. And we have exposure to cues, first imaginary, then in session, and then in vivo, in a healthy, safe type of situation. You don't work with all cues. You only need to identify 3 or 5 that you can work with. You go back to the traumatic stress history to see if the narrative now has changed, and then you start closing. The first time that we did this, we compared to a waitlist group. We saw that there were decreases in PTSD symptoms and decreases in anxiety. And I like to show this one, which shows the decrease of session by session of the whole group, because you see that the biggest slope here is really at the beginning. And at the beginning, a lot of what's happening is education. It's just information. It's just telling the kids that their experience is not a weird phenomenon. It's basically an injury. Many people, instead of calling it post-traumatic stress disorder, call it post-traumatic stress
Часы есть.
injury.
О, спасибо. Да, по-любому в рюкзаке будем. Ты с ней не купался, Франк. Ты ж не брал.
Колеги, вимкніть, будь ласка, мікрофон, у кого вмикнено.
Не, он
Thank you.
просто говорит,
Alex, please turn off the microphone. Who is talking is not a meeting.
So post-traumatic stress injury, which means your HPA axis, everything needs to get back into the rhythm, right? It's like when you cut your arm and you go to the emergency room and they put it back, it's gonna hurt, but it's gonna help. And that's the process of therapy as well. So let's go back to Sammy. And remember, he's the 11-year-old boy that was showing aggression. He was physically abused by his father. Now the father has been deported. So CCT would show at the beginning education into those PTSD symptoms. And what happened was that mom also learned about those. So parents don't have to be at the session, but sometimes they come, and that's wonderful. But mom, who also had PTSD, by the way, helped to manage Sammy's nighttime episodes. And despite the initial resistance, Sammy found relaxation exercises gave him a sense of control and a feeling of calmness. And with support, so he put it in his toolbox. With support, guidance, and a structure means to avoid suggestion. And this is very important. Sammy started talking about his narrative. The way to avoid suggestion is that you think of an inverted triangle or a funnel, right? Where your questioning is very general at the beginning. So you don't start by saying, did that make you sad? Because that's very suggestive in a way. And maybe they'll say yes, and they'll never get to talk about how angry it made them, right? So you really want to start very broad, and as you gather more information, then you can have more pinpoint questions at the end. He felt safe now, and his sense of security increased further as mom learned not to avoid him. For mom, Sammy was a cue. So she was actually not paying that much attention to him. He also talked about missing his father. The fact that he had been deported brought a whole set of issues because, yes, we had some really tough times with him, but not every single day was bad. Sometimes he would go to the park. Sometimes we would have ice cream with him, and that's gone too. And he needed to talk about that. And he needed to know that he could have different experiences, different feelings, right? He could feel safe and secure and enjoy the fact that his father was not around, and he could miss the good times that he had with him. During the aggressive episodes, he felt confused, as in a daze. His heart rate would accelerate. And he had made this connection between that, his dad's aggression, feeling this way, and so he brought the aggression back, right? He identified with the aggressor. And then after hitting his siblings, he would feel guilty, he would feel ashamed. So they were the child and the mom were introduced to this concept of traumatic cues. His father's violence was explored as a fearful event. The cues surrounding the event were most commonly neutral. But it was Sammy himself who brought into this that the slamming of the car door when mom was getting home reminded him of his dad slamming the car door when he was coming home. And then when he hears that, he starts getting aroused. His brain associated this cue to aggression. So the mom is like, oh, let's get rid of the car. But I was like, no, the car, there's nothing wrong with the car, right? The car is going to help us through exposure to this slamming of the door. When the slamming of the door happens, a response happens. And the response is that square. A response is characterized by a cognitive piece, by a physical piece, by an emotional piece, by a behavioral piece. With each kid, you start in different corners depending on how they are. So we concentrated on changing any of these components as a means to develop more appropriate responses. Although impossible to identify all cues, our ability to address some cues helped Sammy make a connection between history and behavior. The goal was not to get rid of the cues, but to be able to tolerate them as non-threatening. And we did the exposure, and this all built self-efficacy. And by termination, he was doing better at school. He was not arguing with his mom. He was not hitting his siblings. And he was feeling a lot better about his accomplishments, and he didn't have as many of the PTSD symptoms. We took this further on another study and compare it to trauma-focused CBT, who's a gold standard treatment as well of children that have PTSD, and also compare it to treatment as usual through a number of measures that demonstrated symptoms, degrees of symptoms, but also through functional near-infrared spectroscopy. This is another functional method. It's not an MRI, and it only gives you cortical information, not subcortical, but it's better time-wise, not that great spatially, but it's great time-wise in that you can see the reaction right away, and also it's less intrusive and less expensive than an MRI. This is what FNIRS looks like. And what we published was that there was a clear link between improving in PTSD and with the treatments and activation of the prefrontal cortex. So the treatment was activating the prefrontal cortex. The prefrontal cortex was making symptoms decrease. And we didn't see this with treatment as usual. So this is all treatment. In terms of prevention, right? What can we do to avoid individuals to develop PTSD? We work with schools and we train teachers to train their students. And we do this curriculum called Pure Power Curriculum, which is available free in English and Spanish and Ukrainian through purepowerinc.org. By the way, many of you have also trained in cue-centered therapy on our training program. So there is information with that I will share at the end. The Pure Power curriculum of movement and mindfulness is available free at their site. You just have to register and you're able to get it. We tested that and we demonstrated that those kids that went through the curriculum versus another school district that didn't go through the curriculum demonstrated a decreased amygdala reactivity and importantly, improved sleep. The kids that went through the treatment slept on the average 73 minutes more, and the kids that didn't go through the sleep. And actually, also, this was deep sleep. This was good sleep. Okay, I apologize for these red lines that are showing here. I don't know why they're showing here. So one of the things that we are addressing now is how to not only think about stress and trauma, but think about resilience and how to build that resilience. Or better yet, a better word than resilience is really adaptation. Adaptation denotes evolution, right? Resilience is a physics term. It means the coil comes back to its original position. Many times after these experiences, we don't want to go back to our original position. We want to go back to a better place, a place that protects us from falling into that situation again. However, we know very little about resilience and adaptation. We know that having a sense of humor is good. We know that having IQ is good. We know that having someone protecting us is good. But is there something innate in children that seek the relationship of someone to protect them? Is there something innate in a children that helps them process cognitive information in a way that's going to protect them, or develop coping skills in a way that's going to protect them? Well, one of the things we are doing at Stanford is that we are exposing organoids, which are these neural cells that coalesce and form groups derived from stem cells, but they're neurons in this case, and we expose them to cortisol, and at different amounts and at different times. And then we kind of assess what genes were involved in them tolerating the insult. And what we've seen, and this is work that is starting, is that a lot of these genes code for PTSD, but a subset of them, which are novel, we have found are related to collagen formation. So we really want to look this deeper. And what we're doing while we're disseminating our treatments, both the yoga and mindfulness and the Q-center therapy, is that we're also getting vocal swabs to see if these genetic markers that we found are present in kids that improve from one or two of the treatments. So what we're doing in Puerto Rico, and why Puerto Rico? Because it has experienced a lot of natural disasters and psychosocial stressors and academic stressors, is that we're training teachers on the yoga and mindfulness curriculum on Pure Power, and training counselors in Q-center therapy. They're implementing this with their students, and we're assessing students, teachers, and counselors before and after intervention, and getting the vocal swabs, like I just mentioned, from the students. This is a study that is just starting. These are the measures that we are getting from all of them. And that's where we are. So I look forward to sharing the results of that study with you. I want to thank the foundations that supported the work that I presented to you, and of course, the team that works with all those findings. And I want to thank you for your attention, and also have some time here for discussion and questions and answers.
Well, thank you so much. And we do have a lot of questions, really, but I would propose for us to start with the following. Our participants are asking, could have you then share with us the information on the training program that you mentioned during your presentation, just maybe in as a letter after the meeting, and then we can share it with the participants if it's possible, if you would be so kind.
Yes,
I think
so
they're referring to Pure Power.
yes, so two things. One, Q-center therapy is on our website, and our website is early life stress and if you just write early life stress and resilience program at Stanford, the page comes up, elsrp.edu. And then the pure power comes from pureedgeinc.org. And yes, we will share these links with the organizers of this talk so that they can share them with the rest of you.
Чудово, дорогі учасники, ми
Oh,
всім
thank you so much,
поділимося.
dear participants. We will share everything as soon as we have it. So then let's move to more precise questions to the point. The first one from Natalia. How do you select an intervention for adolescents with the chronic traumatic experience? For example, if the situation is when there has been violence in the family.
Yes. So this has come up a lot, right? Because right now our treatment intervention is from 8 to 18, and we see a lot of people in their 20s and even later needing this type of intervention as well. I think it can be used. I think I have used it. Colleagues of mine have used it with adults. It's important that I say that all the research that I've presented is between those ages of 8 and 18. And but adults that have very complex histories of violence, interpersonal, war, child maltreatment, all this accumulation of things. This is exactly why Q-center therapy was designed for the accumulation of stressors and of trauma. There is a manual for Q-center therapy, but there's soon going to be a second edition. This is through Oxford Press. And in that second edition, there's going to be a section on how to apply it with adults, because we've done it and so many people are doing it. And how it applies to preschoolers, to those individuals younger than 8, that's a different subject. That is more complicated. And we have an interest in doing that as well and have a team that's going to be working on that, but that's going to take a little more time.
Дякуємо за вашу
Well, thank you
відповідь.
so much for the answer. The next question that we have, working with adolescents that been through loss through the war or become an internally displaced people. So like a father or mother die because of war, and then they become an internally displaced person, and she is emotionally detached and she is hypervigilant. Is there any scientific approach that help to stabilize their state before the profound therapeutic work will start? So is there anything before the therapeutic session that you can do to stabilize them?
Yes. So in terms of loss and in terms of grief, we see this as a trauma event, but it is somewhat different in that it is a loss of a very important link that is irreplaceable, cannot be replaced. So the aspect of grief, I would look at the aspect of grief separate from the aspect of post-traumatic stress and try to address this separately. In this particular case, we have someone who's so dissociated or hyper-aroused. Usually it's one or the other, but we do have individuals that bounce from one to the other, that sometimes you cannot start therapy because they're not listening, right? They are not engaging, and that avoidance is very big there at the beginning. Sometimes we look at that as comorbidity, and sometimes an SSRI medication may help calm the individual so that they can engage in treatment. Sometimes, depending what the issue is, if it's lack of concentration, a stimulant can also help them. But the worry about that is the belief that the medication is going to take care of everything, or that this child is only going to be treated with medication, which we have a problem with. We know that children are being over-medicated, and the medication alone may not take care of it. So I would suggest in this particular individual to see if there is any area that is open for discussion. Maybe it's not the loss, maybe of the parent, maybe it's not the symptoms of PTSD, but maybe is the loss of the school or the loss of the sport or something that can be a little window to get in that could allow to then enhance the work to cover those other areas.
Дякуємо.
Thank you
Дякуємо за
so
таку
much
розлогу відповідь.
for such a detailed
І
answer and
таке
for
загальне питання.
and then
З
more of a
вашого
general
досвіду,
question from
по
your
ваших
experience
рекомендаціях, як
and on your
підібрати
recommendation.
ті
Like, how do you select the
методики і
cognitive
техніки
technique and
релаксації,
the relaxation
яких варто
techniques
було би
that
навчити
would be
дитину?
good for a
Чи
child to know
можливо
or to
у вашій
learn?
практиці ви
And maybe in your
помічали
practice, you
якісь
notice like that there is like some of them they're more effective or some of them more sticking in, maybe because of like the generations changing or something else or something that sticks more to the child or helps more.
Yeah, like the question is implying that clinical experience has led me to bring a group of things that I think work. For example, when we talk about cognitive, how to change a negative thought to a positive thought. Um, and also really assessing the number of negative thoughts that are happening. Sometimes the negative thoughts are real at the beginning, but then they start becoming less real because they become kind of automatic. And we automatically, all of us, think negatively. It is how we have survived, right? But the reality is that it is the prefrontal cortex that you need to activate to think more positively. And sometimes that area is not active enough or it hasn't evolved enough, like the limbic system, to think positively. So, you know, that's one of the things that we teach, like, oh, let's check out the data. Let's see if we are over catastrophizing. Let's see if this is 100% negative when we are examining negative thoughts. Then mindfulness is something that my team had tried personally for us to do the type of work that we do to take care of ourselves. And we saw the impact that it had in ourselves. So mindfulness then was a way to share it with the schools and with the students. So those are two small examples. But the most important thing here is that it's not the exercise itself, but it's to teach how the individual has the capacity to develop options that are going to improve him or her. So not only we teach things, but we invite them to include in their toolbox things that we have not taught them that they do. And they have seen that works and helps them and things that they like. And uniformly, almost universally, when kids do that and they use their own tools, they work better than any of the tools that we teach them. There again, this point of empowerment and of self-efficacy.
Дякуємо.
Oh, thank you so much.
Things like, you know, things like music, things like dance, sports, talking to a friend, things like that.
Дякуємо.
No, thank you so much. Thank you. The next question that we have is how does this traumatic experience influences the development of prefrontal cortex in the adolescents, and which kind of techniques can help the development even in chronic stress conditions?
Yes, so what we believe based on our work is that the development of the prefrontal cortex is going to be delayed through traumatic experiences, and that this is going to impact attention, concentration, executive function, the ability to organize, to place things in order, to triage. But also what I hope you got out of this talk is that it doesn't mean that that cannot change. We can actually change it with the right intervention, with the right psychosocial intervention that engages the prefrontal cortex not only to be active, but to practice different techniques. And then the neuroplasticity allows for the prefrontal cortex to catch up on the development. So, and I would say, forget about it's not only about the interventions that I have talked about. Anything that you think that activates the prefrontal cortex is worth bringing into the picture. A game, a sport, conversations, whatever it is important to engage it and not to assume that it has been damaged or not developed and that it cannot perform as well. Because it can. It can with the right intervention.
Well, thank you so much. And the next question, are there any exercises that directly influence the connection between the amygdala and the prefrontal cortex so that the adolescents can control better their emotion in the stressful situation?
That's a very good question, and that would be a very good study to do with the right design that's able to evaluate this communication between the two. We have not done that directly. We have looked at the amygdala separate and the prefrontal cortex separately, and they both do better with our interventions. The amygdala does better with the yoga and mindfulness, and then the prefrontal cortex does better with the Q center therapy. But that doesn't mean that the Q center therapy doesn't help the amygdala. That doesn't mean that the yoga doesn't help the prefrontal cortex. So a combination of these two interventions, which is why we're going to schools now teaching both, may make those paths better. What we're talking really is about myelination, right? It's the conduction of one to the other. So a lot of things are going to influence that. Psychosocial intervention, good nutrition, early intervention, all of these things are important.
Дякуємо. Докторе Керіон, ми дамо вам буквально секунду.
Thank you so much. We'll give you a second to rest from the questions because we have so many, so let me summarize it. And I would just like to make a great announcement for our participants that Dr. Carrion have been a guest in the podcast. It was the Simple Words, and I think that you've been our listeners at that time. Therefore, you can find the recording of that talk at the webpage, the Village, or the social media of How Are You, and the How Are You platform. You can revisit or re-listen to that podcast before. But we have two additional questions that are connected with the topic of sleep. What would be the specific neuroscientific backed methods you would recommend for the self-regulation before sleep if an adolescent is being in a constant hyper-aroused state? They're constantly hyper-aroused.
Yes, I really would recommend that you go to pureedgeinc.org and go to a section called Brain Breaks. And the section of brain breaks are short, easy exercises to do, to be mindful and to be relaxed and to meditate and to have this become a habit. You don't only do it on bad days, you do it every day, like brushing your teeth. To have it become a habit would be very helpful. And we already know that this intervention is increasing the amount of time in sleep and increasing the depth of sleep. And the depth of sleep is very important because it is during deep sleep that we process the emotional events of the day. So a child that tends to be hyperaroused at night, doing these exercises, and this could be individual or family or in group or whatever version you want to do it, that won't take too much time, would help. Of course, we also always have to be open to the communication with our children, right? To sit next to them and ask them, how was your day today? Tell me about it. What was bothering you? And this is a time where they usually like to talk about what happened to them. So getting this information out is important. Sometimes they're not going to want to talk to you, and that's fine too. Especially as they get older and become adolescents, right? They're going to want to be more independent and isolated. But at least your willingness to engage in communication lets them know that the channels of communication are open, for that when they are ready to talk, they know who to go to and when to do it. So I would say making sure there's good communication, acknowledging what they are experiencing at the time, not pretending that they're not hyper aroused, because they're going to do this relaxation, accepting, yes, this is an anxious time, but also creating a new habit of building brain breaks.
In continuing the topic of sleep, we have a question from Alina. She is saying that she's consulting veterans of war, and which kind of techniques can you recommend during insomnia? A veteran cannot fall asleep. They're constantly seeing the wartime action, deaths, and injury of his beloved teammates or countrymen or something.
Yeah. So sleep can have a very heterogeneous presentation, and there might be many different reasons why someone is not sleeping well, including, caffeine consumption, dietary needs, sleep hygiene. The first thing I would do is develop a sleep hygiene program, and I would look into how to do those. Usually those involve, which is hard at this time, really decreasing the amount of social media and TV exposure, specifically after a certain time, usually like 6 p.m., not having any liquids after 8 p.m., no fluids after that time, avoiding caffeine, not taking naps during the day, not using the bed for other reasons other than sleeping. And also, when they notice that they're not sleeping, to not keep trying to fall asleep, to actually get out of bed and engage in some other activity, like reading or writing or something else. And there are different programs like this called sleep hygiene.
Well, thank you so much for the recommendations. And the next question from Oksana. Can a psychological or physical trauma received by the child in a very early age, from 1 to 3 years of age, can influence to the autism, to make autism worse or to make autism less? And so can this trauma delay the development of speech in a child? Because the participants of our webinar is sharing that a child is 5 years of age, but she's not speaking at all, but she's emoting well. So she is expressing joy, compassion, or something. So is there anything we can help her with?
Yeah, so this is a very general statement I am going to make right now, which is trauma doesn't happen only to healthy children, right? Trauma happens to children that have other conditions, other mental conditions, and other physical conditions. And unfortunately, like I said with play, what it tends to do is to make those situations worse and more difficult. So it may accelerate the process of some of those situations. I don't know this particular case, but it seems to me like the question is, could it isolated affect the autism and not the emotion? Because the emotional life seems to be present in terms of how she's expressing emotions, but the autism seems to be severe. It's difficult to tell. It's difficult to tell. I think family history plays a big role, the loading of the autism, but certainly still the trauma needs to be processed, and then it would be interesting to see what happens to what is being considered autism at this point. And I would take advantage of that fact that she can express some feelings of joy and excitement and things like that. I would use that strength to see how much of the trauma can be processed. If it's something that she's aware of and it's something that the family is open about and they talk about it.
Дякуємо.
Well, thank you so much.
Наступне запитання.
The next
Як
question, we have
можна
lots of them.
тренувати
How can you combine better
моторику та
relaxing
інтелектуальні
exercises and
здібності
bilateral
під час
stimulation for
практики?
children with
Чи
psychotrauma?
є у вас
Is there
такий
like
досвід?
any experience like that in your practice?
I'm sorry, I'm afraid I didn't understand. Combining what two elements?
Так, звісно. Релаксаційні
So the
вправи
relaxing exercises or exercise for relaxing and bilateral stimulation. So like left, right, left, right, left, right. Like EMDR, I guess.
Oh, yes. So I am not an expert on EMDR, so I really don't want to comment on it. I think an important aspect of EMDR is the narrative work that happens. So I would try to see if I could incorporate some relaxation during the narrative piece.
Дякуємо.
Thank you so much.
Які прості вправи
What are they
можна
simple
зробити,
exercises or
наприклад,
simple
вправи
action, for
звички,
example, like
підтримують
exercise behavior
нейропластичність у підлітків?
supports neuroplasticity in adolescents and what does it?
Can you repeat the question again? I'm sorry.
Так. Які прості дії,
Which
наприклад,
simple
робити певні
actions,
вправи або
like if they do
звички,
exercises or they
підтримують
have habits,
нейропластичність у
support
підлітків?
neuroplasticity in adolescents, so that increase neuroplasticity, and which kind of behaviors are dulling or decreasing neuroplasticity in adolescents?
Well, one very important and very simple exercise is to help the development of diaphragmatic breathing. Diaphragmatic breathing means that we really want to bring our diaphragm down so that our lungs expand and we bring more oxygen. And the oxygen goes to the hemoglobin and helps with the relaxation. So one way of doing that, and the instruction to do that, is to put a hand on your chest and a hand in your stomach. A deep inspiration where your breath starts filling your stomach before your chest is necessary, like so, and you are inhaling through the nose, and then you're going to let the air out through your mouth very slowly, almost as if you were breathing through a straw. So that very simple exercise is one that helps relaxation. It's called diaphragmatic breathing.
Дякуємо.
Oh, thank you so much.
Наступне запитання
And
від
the
пані
next question from another
Наскільки
Oksana.
важливий етап клінічної
How important
діагностики
the
та
stage of clinical
диференційної
diagnostics and differential
діагностики на
diagnostics
етапу проведення
before the stage of psychotherapeutical intervention. So how important is diagnostic before you go in with the therapeutical
Yes,
instruments?
thank you so much for this question. In the manual, we have a big section before we start talking about the treatment on assessment. And assessment is very important because you really want to make sure that you're not missing anything and that what you're calling a post-traumatic reaction may be something else, maybe an anxiety disorder, maybe a mood disorder. So you really want to assess, and the assessment is very, very global. You want to assess how things were for the individual, for their family, for their community before the events, and how all of that is now after the event. What coping mechanisms were there before the event? What coping mechanisms are there now? What social support was there before? What social support was there? So you really want to do an assessment, not only for diagnostic purposes, but also for understanding the impact of the event on the individual and its support system.
Thank you. And we remember the post-traumatic stress disorder. There's one question regarding PTSD specific, and I think it's really interesting for yet another Oksana. Does the loss of thirst as the symptom of the PTSD can be a loss of thirst, or strive for water or wishing to drink can be a symptom of PTSD? So the child does not feel thirsty at all. Like they lost it. Can this be a manifestation of PTSD or considered one of the symptoms?
Usually, it depends. Here, the assessment is very important, and it's very important to get a comprehensive history of what role does water play in their lives, from the very practical to the ones that may be more symbolic. So it is difficult to say. Usually, cues and triggers are avoided. So if water was a cue or a trigger, they wouldn't be seeking it. They would be more like avoiding it or being afraid of it. But the wanting it could have many different meanings. It could be within a picture of PTSD, and it could be within the picture of other endocrinological or other conditions as well.
Thank you so much. It's an interesting question. Also, is there a point to explain to adolescents what is happening to them on the brain level during stress, and how to do it in a way so that the adolescent can not to be frightened by it, by what it is and what is happening? So how do you explain it to adolescents?
I explain it to kids not much that different than I explain it today. One of the things that I say is that there are no secrets here. Children that experience trauma, might have secrets involved with their trauma. When we treat them, we want to be very upfront. We want to be very clear. Yes, you're bringing a message that could be scary, but you're also bringing a message of hope and a message of repair. Think of yourself sometimes when you have something and you don't know what it is, how anxious you are. Then you go to the doctor, they tell you what it is, and maybe it's not the best of news, but you feel better because you know what you are targeting, you know what you're attacking. And the same thing with a kid. It's important for them, the realization for them that this is something that happens to other people. It's it's such a revelation that it in many ways is part of the healing process. So you want to describe it, and yes, you don't want to scare them, in the way that you talk about it, but you want to acknowledge that there are real effects for the experience that in a way cause both physiologically and psychologically the way that you're behaving now. And the beauty of it is that by working with it, not only behavior can change, but that psychology and that physiology can change as well. And of course, you adapt the message to the age group that you're working with.
Дякуємо.
Thank you so much for sharing. And Eugenia is asking for your recommendation. What are the best techniques to fight the panic attacks?
Yeah. So panic attacks are common, and many individuals can have panic attacks and not have panic disorder. These exercises on relaxation and on breathing are a big part of it. Gradual exposure can also be a part of it. Cognitive work can be a part of it. Many times individuals have panic attacks because they are afraid of having another panic attack. So sometimes it pays to get into those thoughts and see how those thoughts could be controlled or managed by having discordant thoughts or different thoughts. So there are a number of ways, both cognitively and through relaxation of addressing that. Usually the individual with panic attack thinks like something horrible is going to happen, that the worst thing is going to happen. And one of the cognitive techniques is, instead of avoiding it, think that it happened. Think that it actually happened, and how would you survive it? And sometimes that helps some individuals. It's a type of treatment that is very individualized.
Дякуємо, дякуємо.
Thank you so
Наступне
much.
запитання. Що
Next
можна
question,
зробити у
what can
випадку,
be
коли
done in
дитина
case
не
if the
витримує навіть
child
мінімального
does
занурення у
cannot hold
травматичний
any
спогад?
kind of deeping in the traumatic memories? If the child is so does not want to rejects or something going in there, that what can be done if the child is just resistant?
Yeah, sometimes that is the case, and you do need children to be motivated. That's part of this treatment. Um, and so sometimes what I try to do is, are they open to having therapy about something else other than the trauma? So that they develop a relationship first, they gain trust first, they lose the fear that something terrible is going to happen in that relationship or that therapy, so that they overcome that. And sometimes when you do all of that, they become ready. Sometimes they don't, and you just have to wait.
Дякуємо.
Thank you.
Дякуємо, дорогі учасники.
Thank you so much, dear
Зараз буде
participants.
невеличка
And I would just like to
ремарка
make a small
від
remark,
нашого
and I would like to
спікера
mention that for our
і
speaker and for
якраз наші організатори повідомляють, що
and
нас
our
сьогодні
organizers are
під час
telling
лекції,
that
під час цієї
during the
сесії
lecture and during
близько
this session we have around
1000
1,000
і
people,
тому наш таймінг вже
and
майже
our timing
підходить
is
до кінця, і
almost
я
over,
сподіваюся,
but
що
I'm
ми ще
hopeful
зможемо
that we would be
поставити
able to ask
якісні
one or two
запитання
questions
нашому спікеру.
to our dear
І я
speaker.
зроблю
And
таке
I
оголошення
would make an
про запис
announcement
нашого
also about
ефіру.
the recording of
Дорогі
our broadcast.
учасники,
Dear
є
participants,
таке нововведення від платформи
there
Facebook,
is a new thing from
що
Facebook
через
platform that
місяць
in a
запис
month
може
this
зникнути,
recording might
тому ми
disappear.
рекомендуємо
Therefore, we would recommend
слідкувати
you
за
to watch it,
постерового вебінару і
the
цього
recording of this webinar
слайду
and all the
прямо
previous
на
ones,
YouTube
if need
каналі
be, on the YouTube channel, on How Are You channel.
Добре.
Dr. Carrion, the last two questions, how much time is needed to form new healthy connection in the brain after regular exercises? And are those weeks and are those months? Like, what is the timeline for new connections to form?
So I don't have a direct answer for that, but I will tell you that in my review of meditation studies, it seems that some of the good effects can be seen within weeks. Behaviorally, I don't know neuroscientifically, but behaviorally, we have seen some changes happen right after the intervention. Now, what's interesting is usually that neuroscientific changes happen before behavioral changes. So then one would assume that the neurofunctional changes might be more immediate. So I think it's pretty quickly.
Дякуємо.
Well, thank you so much. And the question from Irina, if a person is shaking all the time, the body is shaking, legs are shaking, like as if they're being like hit by a current of electricity, happens without reason a few days after a stress event had happened. Do you think that this is a panic attack, or maybe this is something like connected with the maybe morphological changes in the brain? So she's saying that the doctors did not find anything on MRI and ultrasound diagnostics, so the brain's clear, so they didn't find anything, but the child is just shaking after that traumatic event.
After ruling out medical conditions like seizures or electrolyte imbalances or things like that, and assuming that this is behavioral, I would invite the therapist and the child to examine the square that I was talking about, where the shaking is the somatic piece. It's only one of the corners. And I would want to know more about the other corners. If you attempt to stop the shaking, that may not work because you're basically asking the kid to give you the only response they have, right? So what you want to do is build competitive responses. In other words, yes, you can shake, that's one response, or we can build another square so that they have more of a choice. But in the shaking itself, which is one square on itself, I would ask, what are your thoughts when you're shaking? What are you feeling emotionally when you're shaking? And what are you feeling physically when you're shaking? And then see which of those corners you can change. Because if you change one of the corners, the whole square changes. And what you want is to have another square, and then build another square, and so on, to have a portfolio of responses, an armamentarium of responses. Right now, the individual may have only one and not understand it that well. So let's get the kid to understand it, and let's get the kid to build more. And also, let's get the kid to understand that there's no threat of taking the shaking away. It will go away eventually. But if that's how you start, that's going to make it very scary.
Дякуємо.
Oh, thank you so
Неймовірно
much.
дякуємо, доктор
Amazing.
Кірін,
Thank you
що
so much,
дуже
Dr. Karen, for
роз'яснили і
being here with us, even though virtually, and for such an intensive Q&A session. But unfortunately, our time is almost over. And I'd just like to remind you that yes, we do have the recording of today, and I'd like to remind you about the podcast Simple Words. There's Dr. Karen that you can listen to in any easy or accessible time to you. And also, dear participants, for you, there's always a platform, TIAC or Havarti program. This is for wider audience, but this is also for experts as well. It's not just for regular folks. And please use it. Please go to howareyu.com, and there's so many good materials. And there's also educational unit where you're able to go through different courses, also on burnout and on other needed things and requests from the society. Yet again, dear speaker, thank you so much. We are wishing you all, nothing but the best, and all the participants, especially who's in Ukraine, to have a peaceful and rockets-free evening and a blissful night, and see you next time. Thank you so much.
Thank you for the invitation today, and thank you all for all the work that you do.